So this is my patient. This is a patient who is a question of what to do next. So this is a 68-year-old male who had been referred to me for adult spinal deformity with complaints of stooping forward and complaints of bilateral sciatica type pain. As you can see, the patient has a modest coronal plane deformity with regards to, if you can go back one slide, Asher. With regards to the patient's standing balance, you know, he's slightly positive, but certainly he does not have a tremendous amount of lumbar lordosis. His overall general lumbar lordotic alignment is relatively flat from L1 through S1. He's got about 15 degrees of lumbar lordosis. And you can also see his pelvis is retroverted in the standing X-rays. But certainly, you know, he's not, you know, tremendously positive. He's a thin man. He's able to compensate for his deformity, but it does fatigue him, and he has sciatica associated with it. Next slide, please. And so this is his MRI scan, which shows foraminal stenosis. This is showing it on his left side. He also has some foraminal stenosis on his right. Also, I show the slide to show that he has a preserved disc space at multiple levels in his lumbar spine. Next slide, please. So like many of the surgeons put forth before is what do you do and what do you offer to him? Continued non-operative care, a comprehensive type surgery of multi-level fusion, or the concept that I think both the osteotomy and the potential interbody procedure offer is what I tend to refer to as fractionated surgery. So what I had discussed with this patient in particular was he certainly did not have the appetite for a larger and comprehensive surgery. He had a decent amount of sciatica associated with his symptoms. And what I had talked to the patient about was, well, if you're going to eventually have a major adult reconstructive surgery, for me, stage 1 would be a 5-1 lift. So in this particular setting, what I discussed with the patient was considering just doing stage 1, which was having a standalone A-lift to try to treat his foraminal stenosis and see what kind of lordosis I could achieve. Next slide. So what we see is that I think I think our pictures sort of demonstrate that we in fact did do his standalone A-lift. Certainly did not affect his coronal deformity much. We did get about 20 degrees of lumbar lordosis at 5-1, and I really just show his long-standing sagittal films to show a couple of things. One is that, you know, he had this sort of interesting thoracolumbar frank lordosis that looks a bit better on his post-op standing films. Next slide. And how's he doing? So he's 6 months out. He's happy. We'll use the word happier. His radiculopathy is gone. He doesn't feel he stoops as much, but he still feels he stoops some. And so the question is, with a what could you do next discussion, and he's not ready for it yet, is what would you offer him? So these are his lumbar flexion extension films. And I'll let the audience give their opinions as to whether they think he moves or not through his disc spaces, for which, like I said, his MRI shows he has some preserved disc height. I wouldn't say he has a ton. Next slide. So again, some preserved disc spaces, but certainly not entirely ankylosed. What we do also see is that he has preservation of his facet joints. This is 4-5. Go to the next slide. And this is 3-4. And so throwing out the concept of fractionated deformity surgery, I think it was referred before as deformity surgery light for a coronal plane deformity, is what's the thought of the audience on fractionated adult sagittal plane deformity surgery in this particular patient. What does everyone think about the ALIF, and what does everyone think about what would be next?
Any takers? I see Themi Protopsaltis is on the call. Themi, you have any thoughts? I don't know if you're connected in at the moment, or anybody else.
So what are his new symptoms?
He still complains that he stoops forward. That's it. His sciatica is better, and like I said, he's not ready. He tells me he's not quite ready yet. So no radiculopathy. Still noting that he feels he's stooped forward. So, you know, I got some correction with his ALIF. I got some correction with his ALIF at 5'1". Would we consider a additional interbody fusion? Would we consider an osteotomy? And I'm talking anterior osteotomy. I'm talking a vertewedge osteotomy with the preserved disc basis, or right now what's happening is like I said, he's on cruise control and thinking about life.
Well, if he's not miserable enough, nothing to do. You know, just continue until he's absolutely miserable. But then
Praveen,
if he's miserable, then, you know,
Go
then
ahead,
probably
Puya.
he's going to need a bigger operation.
What would you do, Puya? If
Yes.
Can you go back on the standing scoliosis X-ray after your ALIF? You know, if I have to do this and the patient is absolutely miserable, because as we know, they all come back. You know, the more level we do, the faster they come back. It's called back surgery for once, the same reason. So I would do all through the back, a T10 to pelvic on him.
It looks like it needs an L4 PSO.
Well,
Or, you know, or does it need like multiple interbodies?
yeah, I think with the
laterally.
good, you know, if the disc bases are still good and they're not fused, I think by just doing multiple level TLIF, another 2-level TLIF at 3, 4, 4, 5, you should be able to get enough lordosis. Spending enough time on those TLIF carpentry, you should be able to get ample lordosis. But again, it's going to be a humongous operation with, you know, one day coming back for adjacent level disease or a PJK.
Right, but
Praveen, maybe you can chime in. Praveen, you had a thought.
Yeah, the ALIF has already been done. I don't cherish doing a redo ALIF with a bunch of scar from the last ALIF. But going lateral here, I think is interesting. I think you need more lordosis. So maybe this is one that I would think about, that mid-body VBO kind of thing. Because if you can get a lordotic cage in there, and then the question becomes, would you do it at L4? Would you do it at L3? L3 is probably technically easier, less risk to the plexus nerves than doing it at L4, which is really a tricky, even for XLIF at 4-5 is tricky sometimes with the plexus nerves. And I don't know, getting it at L4 is going to be super easy. The position of the pelvis is the other thing you kind of have to worry about. So the question is, you know, if you do the osteotomy at L3, will you mess up your, you know, your lower lumbar lordosis, you know, to your global lumbar lordosis, your lumbar index? Are you going to mess that up by doing it at L3? But I think L3 would be the easier technical thing to do. 4 would be more technically difficult given the position of the pelvis and a little bit deep seated to 4. But I would be intrigued by that osteotomy idea in this case.
You know,
So
one more thing,
Praveen,
that if
what
you
if,
go back on the
no.
axial MRI, if you look at L4-5, the psoas are extremely high riding. So, you know, the L3-4 is functioning more likely as an L4-5. So again, it's going to be difficult for any of this lateral, either inner body fusion or the osteotomy device. So I agree with Dr. Muminetti, L3-4, a better, safer option.
I
So-
agree. I would not touch an L4-5 lateral here with that. That's like even beyond Mickey Mouse. So that's like Mickey Mouse plus.
So Praveen,
Randy?
you do a lot of pedicle subtraction osteotomies. We've been working on a posterior approach with the osteotomy. So it seems to maybe answer that issue about L4. If you could do that osteotomy without a fusion from posterior to L4, would that be interesting?
That would be more interesting because you would get your lumbar distribution to be lower down rather than higher up, which L3 might put it a little too high up actually, and L4 would be more harmonious.
Stay tuned. We hope to have that coming.